Hello, I'm a fourth year medical student, and today we're going to be taking a look at the pulmonary exam. This is my patient, Paul Goodwin. Before we start, it's always important to wash your hands, and in this case, we'll just use some hand sanitizer. The pulmonary exam is broken up into 4 parts. The first part is inspection, second part is palpation, third part is percussion, and then you end with auscultation. To start with inspection, first we want to take a look at the patient's respirations, and that includes respirations per minute, which is the rate, the pattern, and you want to take a look at effort. A good way to do this is to take the patient's pulse and watch their chest rising and falling, so that way the patient doesn't consciously alter their respiration rate or their pattern. The normal respiratory rate is anywhere between 12 and 20 respirations per minute. Taking a look at the pattern, you want to make sure the pattern is regular without any interruptions in breathing. And with respiratory effort, you want to take a look at the patient's accessory muscles, and that includes intercostal muscles, neck muscles, and trapezius muscles, and make sure that they're not being used, because that can indicate respiratory distress. After doing that, take a look at the patient's anteroposterior diameter and lateral diameter of the chest and compare the two. In a normal healthy patient, the anteroposterior diameter is about half of the lateral diameter. So in this case, our patient is healthy. In a patient with a 1-to-1 ratio, that's usually more of an indication of barrel chest, in which you would see in a patient with emphysema. And in that case, the ribs, instead of pointing down, will be more horizontal as well. Finally, for inspection, you want to take a look at the patient's skin and mucosa. Any pallor or paleness could be a sign of poor oxygenation. Finally, take a look at the patient's nails, and any softening of the nail bed, any decrease in the angle between the cuticle and the nail bed, any curvature of the nail, or any increase in the distal aspect of the finger could be a sign of clubbing. And that's usually associated with patients who have long-term respiratory diseases such as lung cancer, emphysema, or cystic fibrosis. Next, we move on to palpation. What you want to do here is, first we're checking for chest expansion. So you want to put your fingers or your thumbs at T10 on the patient's back, place your hands around the rib cage, and ask the patient to take a deep breath in and exhale. And here you're watching for symmetric rise and falling of your hands, which indicates equal chest expansion on both sides. Next, what we're going to do is tactile fremitus, and here you use the bony aspects of the ulnar side of your hand, and place it in 3 places on the patient's back, and ask them to say the word 99. So Paul, do you mind if we undo the gown?
That's okay.
Okay. So you ask the patient to say 99, and when you do that, you're checking for equal vibration on both sides. Make sure it's symmetric. That's any increase in fremitus or increase in vibration is usually a sign of consolidation or mass, and any decrease in fremitus is more a sign of air trapping, such as an emphysema. You say 99 for me.
99, 99, 99.
Okay, very good. All right, for the next step, we move to percussion. And here, you want to use brisk hand movement to be tapping on the patient's back with your hand placed over it. And again, you're checking for consolidation here or air trapping. Hyper-resonance is usually a sign of air trapping because you'll hear the sound better. Dullness to percussion or hyper-resonance is more of a sign of consolidation. And remember, always make sure to compare both sides and make sure that the sounds are symmetric. Finally, we move on to auscultation. Now, here, typically you want to listen to the patient's lung sounds in 3 places on the back, 1 place on each side under the axilla, and 1 place on each side on the front, on the anterior of the chest. And you're listening for any crackles or wheezes or pleural friction rubs. When you feel my stethoscope, just take a deep breath in and exhale, Paul. for the next step in auscultation, we're going to be taking a look at egophony. In egophony, you ask the patient to make a long E sound, and what you want to hear through the stethoscope is an E sound as well. When the E becomes more of an A sound, then that's usually a sign of consolidation. The E to A transition can be indicative of pneumonia or any kind of inflammation in the lungs. So Paul, when you feel my stethoscope, please just make a long E sound, okay?
E, 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 E.
The last step is whispered pectoriloquy. In whispered pectoriloquy, you ask the patient to say something like toy boat in a whisper, and usually you should barely hear it or not hear it at all with the stethoscope. If you hear it louder than you would expect to, that's a sign of consolidation, since sound travels faster with less degradation through solids and denser material. Please say or whisper toy boat for me, Paul.
Toy boat. Toy boat. Toy boat. Toy boat. Toy boat. Toy boat.
Okay, and that's all for the pulmonary exam.